Hello everyone. So today we are going to discuss about approach to autoimmune hemolytic anemia. So this particular condition, I think during your clinical rounds, during clinical workups of number of diseases, we come across autoimmune hemolytic anemia. But to get an ideal approach to autoimmune hemolytic anemia, we need to know why the major cause for autoimmune hemolytic anemia. So today we are going to discuss about all of these things. So what is autoimmune hemolytic anemia? So it's a collection of disorders characterized by the presence of autoantibodies that bind to the patient's own erythrocytes, leading to premature red cell destruction that is called hemolysis. So it's always we need to there is not one condition which goes around during these disorders. There are 2-3 conditions which happen at the same time, and knowing which one to manage first is the most important thing. So rate of hemolysis exceeds the ability of bone marrow to replace the destroyed red cells to anemia and its attendant signs and symptoms. So, majorly, autoimmune hemolytic anemia are of 3 different types. That's called warm reactive AIHA, paroxysmal cold hemoglobinuria, and cold agglutinin disease. So, warm reactive AIHA and PCH, both of them, the predominant autoantibody is IgG. Coming to cold agglutinin disease, it is IgM. And as you can see in the table, PCH and cold agglutinin disease are essentially cold antibodies, and the IgG subtype of warm reactive AIHA is warm antibody. So what is warm, what is cold? When I'm saying warm and cold, so when you do a DAT test, so at 4 degrees centigrade, it's not typically performed, but at 37 degrees centigrade, it comes positive for IgG, and that is with or without complement 3. So in PCH and CAD, so at 4 degrees centigrade, PCH is positive for IgG and C3, and at 37 degrees centigrade, it's negative for IgG and positive for C3. And in the table, you can see at 4 degrees centigrade for cold agglutinin disease, it's negative for IgG and positive for C3. And at 37 degrees centigrade, it's negative for IgG and positive for C3. So coming to antigen reactivity, Rh antibodies are predominant in the warm reactive AIHA, followed by PCH-P antibodies are antigen reactivity is quite prevalent in PCH, and in cold agglutinin disease, capital I or small I antigen reactivity is predominant. So spleen is the major site of hemolysis for warm reactive, and intravascular hemolysis is most common in paroxysmal cold hemoglobinuria and cold agglutinin disease. So when I'm saying intravascular hemolysis, generally what we do is urine for RBCs, urine for hemoglobin. So that comes positive in PCH and CAD. So the first line therapy for PCH and CAD is to avoid the avoidance of cold surroundings, so cold, anything which is avoidance of that temperature is because of the antibodies. And warm reactive AIHA, the first line therapy is glucocorticoids. I think everybody, we come across warm reactive AIHA in quite a number of conditions, and we by default we think of steroids and we start off steroids, but it's essential to have these two entities also in mind, PCH and cold agglutinin disease, and treat according to that. So secondary therapy for warm reactive is splenectomy and rituximab, and PCH it is glucocorticoids, and cold agglutinin disease is rituximab. Here I've just enumerated the conditions in which all of these can happen. So in the warm reactive AIHA, it is again divided into primary and secondary. So secondary conditions are number of things. So that's called autoimmunoinflammatory disorders, Evans syndrome, PID, AID, malignancy, infection, and post-transplant. And coming to cold agglutinin disease, again is divided into primary and secondary. Primary, we don't really know the causes, so it just evolves, and we just have to treat it based on the cold agglutinin sensitivity and all of these things. And in cold agglutinin disease, the secondary causes include mycoplasma and EBV, and malignancy is lymphoma. So next comes paroxysmal cold hemoglobinuria. And then we have another entities like primary, like I've discussed, and post-infectious causes. Infection in any form, any kind of infection can trigger AIHA. It's just about we have to keep all of this in mind when you're approaching a child with AIHA. So here I've just differentiated between primary AIHA and secondary AIHA. In primary AIHA, RBC antibodies are present and cause hemolytic anemia, but there is no evidence of an underlying systemic illness. So systemic illness present, that is secondary AIHA most likely, and primary AIHA is there is no evidence of an underlying systemic illness. And here in secondary, you can see there is a systemic illness, and that's called secondary AIHA. So primary AIHA accounts for 40 to 50% of pediatric AIHA cases. And in secondary AIHA, it's a warm reactive antibodies, except post-infectious, typically they are called by cold agglutinins. So here you can see for secondary causes, what all you have to evaluate: SLE, AIHA, autoimmune or inflammatory disorders. And coming to and primary AIHA is mostly warm antibodies. So autoimmune diseases include SLE, Sjogren's syndrome, scleroderma, JIA, dermatomyositis, vitiligo, ulcerative colitis, autoimmune hepatitis, type 1 diabetes. So all of these conditions are autoimmune. And children with these disorders have a genetic susceptibility to immune dysregulation, and which leads to expansion and proliferation of autoreactive B lymphocytes. So sometimes infections can trigger, like in EBV, there is secondary lymphoproliferation and there is expansion of B lymphocytes. But also, we have to, when there is a genetic susceptibility to these immune dysregulations, that leads to expansion and proliferation of autoreactive B lymphocytes. And if there's a family history of autoimmune disorders, sometimes SLE has weak positive DAT without clinical or lab evidence of hemolysis. So that's not considered to have AI. That is not, it's not necessarily that it's called AIHA. So, but we have to have a close watch about number of differential diagnoses when you're approaching these cases. So this is immunodeficiencies, Evans syndrome, malignancies, infection, transplantation, drugs. All of this can trigger AIHA. So annual incidence is 0.8 to 1.25 cases per 1 lakh children. It's more common than acquired aplastic anemia, but less common than ITP. It can affect any race or ethnicity and can present at any age. Adolescents and young children less than 2 years old who present with AIHA are more likely to have an underlying systemic illness. That's called secondary AIHA, and it is a more chronic course. Clinical presentation, it's non-specific. Symptoms determined by severity of hemolysis, and clinical presentation may range from asymptomatic to severe life-threatening features. Presenting symptoms include weakness, fatigue, shortness of breath, dizziness, pallor, jaundice, icterus, and painless dark urine. Other non-specific symptoms include abdominal pain or fever. Warm AIHA is you have pallor, jaundice, and fever. Sometimes they're all well compensated to profound anemia and severe life-threatening presentation also. They are well compensated. In that conditions, we have to aggressively find the cause and treat the cause, or else it just progresses into a life-threatening situation. LFTs, having said all of these things, LFTs, sometimes LFTs are not deranged. There is only AIHA or Evans syndrome. And that particular condition, we should rule out malignancies, lymphomas, autoimmune conditions, immunodeficiencies, and all of these conditions. Cold agglutinin disease, how they present is acrocyanosis. They have purple to gray discoloration of the skin on the most acral parts, that is called fingertips, toes, nose, and ears. These changes disappear upon warming. Passage of painless dark urine in colors ranging from gold to red to black usually signifies hemoglobinuria, secondary to intravascular hemolysis, and suggestive of cold reactive AIHA, such as cold agglutinin disease or PCH. Patients with warm AIHA do not typically have hemoglobinuria unless there is a component of complement fixation. So this picture, in the first picture, there is spirochetes in patients with warm AIHA. Originally, that's in magnification, that's magnified. That's a spirocyte which the arrow is pointing out. And then in B, you can see there is red cell agglutination in a patient with cold agglutinin disease. So you can see that the RBCs are all clumped into one. That's called red cell agglutination. So these are the key features of AIHA, and then how you differentiate between cold agglutinin disease and warm AIHA. So coming to patient history, you have to find out the previous similar episodes, any benign previous medical history, history of autoimmune disease of PID in first degree relatives, any recent acute infectious illnesses, signs and symptoms of underlying systemic illnesses, and concurrent medications. So when we evaluate for CBC, RBCs and platelet count, RBC indices, red cell count, peripheral blood smear, DAT, cold agglutinin titers, urine analysis, and kidney function tests. So serum markers of hemolysis are bilirubin, LDH, AST, ALT, haptoglobin, and plasma-free hemoglobin. In this picture, you can see how we approach hemolytic anemia. Sometimes, even when you do a hemolytic anemia workup, sometimes they can be negative in the first go, but then when you again do it when the disease is progressing or when there is a secondary AIHA and there is a primary cause which is progressing, that time you can find another DAT which is positive. So here you can see hemolytic anemia. If there is a DAT positivity, then we have three DDs in our mind. Either it's a drug-induced hemolytic anemia, alloimmune hemolytic anemia, or autoimmune hemolytic anemia. And when it's DAT negative, it is either hemoglobinopathies, sickle cell disease, infections, malaria, clostridium, enzymopathy, G6PD deficiency, thrombotic microangiopathy, thrombotic thrombocytopenic purpura, and membranopathies, that's hereditary spherocytosis. So how we first evaluate these cases? First, a normocytic macrocytic anemia, raised reticulocyte count, raised unconjugated bilirubin, reduced haptoglobin, and blood smear with polychromasia or more specific features as spherocytes or agglutination. So that's the first step. You have to think of AIHA and then you have to start working up. None of these tests are, again, having said that, none of these tests are fully sensitive or specific for hemolysis. When there is a liver disease that can cause rise in LDH and reduce haptoglobulins, reticulocytopenia can occur in AIHA, secondary to bone marrow filtration by lymphoproliferative disease or parvovirus infection. So sometimes reticulocytopenia doesn't always mean that there is low reticulocytes. Sometimes it can be normal also. Normal or low reticulocytes should trigger us to think about any bone marrow infiltration by lymphoproliferative disease or parvovirus infection. Coming to intravascular hemolysis, if there is a rise in LDH red cell fragments on smear or the presence of urinary hemosiderin, these should raise a suspicion of intravascular hemolysis. After doing all of these things, then we go to step 2. Step 2 is once you confirm your hemolysis, then you further investigate needed if hemolysis is immune by DAT. So like I said, DAT could be first negative, then it could be positive. So we need to have a close watch about how the disease is progressing or how the clinical condition of the child is. Then once we have a standard DAT, it demonstrates IgG. And then you check for the complements also that is bound to the red cell membrane. Then we look for autoantibodies that can be both IgM or IgA classes, and then you do an extended DAT. So here you have the investigations, what I've just told in a nutshell. Here you can see primary evaluation and what are the additional tests we have to do when you're suspecting some things. Hemolytic screens, like I've discussed, then detection of underlying disorders like AIHA, then you have serum immunoglobulins and electrophoresis with immunofixation, then HIV, HBV, HCV, anti-DS DNA, ANA, CT chest, abdomen, and pelvis. Then additional tests in selected patients with AIHA include bone marrow examination to look for any marrow infiltration, be it any malignancy or any kind of thing. Then urine examination, LFTs, clotting, BP, and urine dipsticks to rule out any, this is in adults, mostly in pregnancy-induced TMAs and all of that, we can do that. Infection screening, we should have a close watch about the symptoms, travel history, and age of the child, or, any baby or a child, and then rule out those infections, whatever you can cause. And then peripheral T cell subsets, creatinine, LFT clotting, all children, and if suspected you have Evans syndrome, you have to think of T cell subsets and any immune dysfunction basically. Then you have parvovirus and hematinics, and if reticulocytopenia is present. So additional serological investigations, selected patients with AIHA, if there is a direct agglutinin test, if that is positive for C3D or plus or minus IgG. If you have a direct antiglobulin test which is positive, then you have to think of cold antibody titer. If that is negative, AIHA is still suspected, then you look for monospecific DAT for IgM, G, A, C3D. And then if monospecific DAT is negative, and then you still suspect AIHA, then you should look for red cell LUH. Then we have furthermore, if you have DAT which is positive for C3D and IgG, and like the other conditions which are listed below, you have to think of Donathan-Landsteiner disease also. And then if clinical significance of cold agglutinin is unclear, then you have to think of thermal range of cold antibody. After identifying hemolytic anemia, Then you have to rule out a delayed transfusion reaction from a recent transfusion, allow immune hemolysis following solid organ allogenic stem cell transplantation, and drug-induced immune hemolysis or hemolytic disease of the newborn will be quickly identified by clinical assessment. When considering alternatives, it should be remembered that a positive DAT can occur in passive deposition of antibodies also, or immune complexes in liver disease, chronic infection, malignancies, systemic lupus erythematosus, SLE, renal disorders, and following drug therapy such as IVIG or anti-thymocyte globulin. If no alternative cause is identified, a diagnosis of AIHA can be made. A diagnosis of DAT negative AIHA can be made from following careful exclusion of alternative causes of hemolysis and confirmation by sensitive technique where available, and is also supported by response to steroid therapy. Sometimes when, especially in India in low income setting, when you don't have the resources to run all these tests, once you have a high suspicion clinically and you start off steroids and you start responding, then number of differential diagnoses are excluded, and then you land to the main diagnosis. So this is another picture which shows all of the approach, whatever I've discussed till now, but I can go through it again. If there is an evidence of hemolytic anemia and then you do a DAT, then you clinically assess. So when you clinically assess, so you have to think of alternative causes of hemolytic anemia and a positive DAT. So these are the causes: post-transplantation, post-IVIG, unrelated cause of hemolytic anemia with an incidental positive DAT. So if there are no alternative causes for hemolytic anemia and a positive AIHA, then you can go ahead and do your DAT if only IgG or C3 plus IgG. And if direct antiglobulin test screen at RT, then you have to think of you have to do an antibody titer, and antibody titer is less than 64, more than 64. If more than 64, then you have to do C3 and IgG and also C3, and then you can further clinically assess serological assessment and then deduce is it a mixed AIHA or a cold agglutinin disease. And then if it is negative, you have to look at age, hemoglobinuria, cold associated hemolysis, atypical serological features, yes or no. And if it is yes, it's Donatal Landsteiner, which is positive or negative. If it is positive, it is PCH. And if it is negative, it is warm AIHA. So you have to also keep in mind alternative causes of hemolytic anemia. If cause still unclear, then repeat the DAT by column agglutination method with monospecific DAT. And then you can do Donat-Landsteiner insulin with hemoglobinuria. If it's negative, then antibody found by sensitive test, steroid responsive hemolytic anemia. And then there is DAT negative AIHA. So this is all how you evaluate, how you come to a conclusion of what it is. Sometimes all of these tests are not necessary. Sometimes clinically, a lot of things you can find out just by how the disease is progressing or how clinically the child is presenting. So once you come to a conclusion, then you have the treatment. Treatment options are optimal. First, you have to do an optimal treatment of a child with AIHA. Depends initially first based on the severity and chronicity of anemia, degree of signs and symptoms, characteristics of the autoantibodies, and nature of the underlying disease if present. That can be managed if the anemia is not severe and no signs of cardiovascular compromise is present. So general principles of primary AIHA is first you rule out the cause, such as infection. Then you support with folic acid, prevent deficiency that could exacerbate the anemia. Then you do the compatibility testing for patients requiring transfusions, focuses on identifying the patients, all the antigens ABO, capital C, small c, capital D, E, small e, and K status, as well as the presence of all allo antibodies. And then you do your special techniques to understand if it's warm antibodies or cold antibodies, like I discussed before. Then in very, very complex cases, then you can send for genotyping, in which it is desirable to match for an extended phenotype. Clinicians should be aware that full compatibility testing can take up to 4 to 6 hours, and the units, when in AIHA, they don't they present with number of complications at the initial presentation. So sometimes you can't wait for full compatibility testing. You have to just go ahead and act based on how the child is in clinically. So labeled as compatible because autoantibodies from unmodified patient plasma are likely to bind donor red cells in an indirect antiglobulin test cross-match. Without a history of transfusion or pregnancy, the patient is unlikely to have an allo antibody. If anemia is life-threatening, transfusion of ABO, RH, and K matched red cells may be preferable to waiting for full compatibility testing. Venous thromboembolism prophylaxis, thrombosis risk with hemolysis is still underestimated but remains an important cause of morbidity and mortality in AIHA. In some series, venous thromboembolism events occurred in up to 20 to 25% of patients, usually when hemolysis was active. Large studies have shown higher rates of venous and arterial thrombosis in patients with AIHA, and more recently in those with CAD specifically. Severe or life-threatening anemia depends on degree of onset of anemia. HB less than 5 gram per deciliter, severe and can cause cardiovascular compromise. RBC transfusions, blood bank should be consulted before for the blood compatibility as soon as possible. Despite risk of hemolysis, RBC transfusion should not be withheld from a patient with life-threatening anemia. Like I said before, sometimes you don't have to wait for 6 hours to just find the right compatibility. You just go ahead and do RBC transfusion, and then manage accordingly. Severe hemolytic transfusion with cold reactive autoantibodies, they fix complement and can cause intravascular hemolysis. So strategies include first warm the blood to 37 degrees centigrade before and during the infusion. Beginning the transfusion at a slow rate and checking both plasma and urine samples periodically for the presence of free hemoglobin. And then vigorous hydration in more severe hemolysis with substantial hemoglobin anemia and hemoglobin. So then coming to pharmacotherapy, choice of treatment depends on the type of AIHA. Coming to warm AIHA, like I discussed, first-line therapy, glucocorticoids. Response is more rapid, short-term, and greater experience with glucocorticoids in children with AIHA. Initial dose is severe anemia, HB less than 6 to 7 gram per deciliter, IV methylprednisolone 0.5 to 1 mg per kg per dose every 6 to 8 hours for the first 24 to 72 hours, after which they are transitioned to oral prednisolone at the dose provided below. So you can give a pulse high dose methylprednisolone 30 mg per kg with maximum dose going up to 1 gram OD for 3 days. That may be warranted for very severely affected patients. It's rapidly evolving and severe hemolysis. Mild and moderate anemia, HB more than or equal to 7 to 8 gram per deciliter, and appropriate reticulocytosis can be initially treated with oral prednisolone 2 mg per kg per day in 2 to 3 divided doses. Tapering first few months, HB more than 9 to 10 gram per deciliter, which occurs within 2 to 4 weeks. Steroid dose can be tapered to single daily dose over 2 to 3 months based on serial evaluation of HB concentration, reticulocyte count, LDH, and DAT results. Taper prednisolone to a dose less than or equal to 1 mg per kg per day within this time frame. And if this cannot be accomplished, if the tapering is not at your expected rate or the response is not like what you expect, then you can go to second-line therapy with rituximab, and it should be started to facilitate steroid weaning. Subsequent tapering include dose less than or equal to 1 mg per kg per day. Prednisolone is slowly tapered but not stopped until hemoglobin normalization. Reticulocyte count and LDH haptoglobin through DAT may remain weakly positive. Goal is to stop, but some patients require long-term low-dose prednisolone less than or equal to 0.2 mg per kg per day or every other day to avoid remission. Patients who chronically require doses of more than 0.2 mg per kg per day and those who experience frequent relapses should gradually be started on second-line therapy. What do you monitor? You monitor hemoglobin, reticulocyte count, LDH, DAT, and in OP settings, sometimes you can do lab monitoring once weekly as clinically better. Then you look at the HB level, reticulocyte count, and return to normal and patient stable on low-dose glucocorticoids. LDH and DAT tested periodically, especially after initial response. Monitor patients for 1 year after remission and has been achieved. If persistent positive DAT suggests ongoing autoimmune diseases and warrants further exploration for certain secondary etiologies such as events or SLE. Expected response, stabilization of hemoglobin concentration followed by a slow increase in hemoglobin level and decreased reticulocytosis. 24 to 48 hours rapid effect due to inhibition of Fc receptor, mediated clearance of sensitized erythrocytes. And then when you see a poor response to initial therapy, then you can think of starting on second-line steroid-sparing agents. Sometimes when you do that, there could be some relapses also. So that's very common in AIHA in initial 6 months to 1 year after initial response. So that time you should restart low-dose prednisolone and that was previously effective in maintaining the patient in remission. And then second-line therapy, when you have patients with frequent relapses and those in whom remission cannot be maintained or maintained off prednisolone or low-dose prednisolone, then you should be treated on second-line therapy. So what are the second-line therapies? So rituximab 375 mg per meter square in conjunction with steroids to attempt weaning of steroids, given once a week for 4 weeks. Response within 2 or 4 weeks. If relapse, a response you achieve it within 2 to 4 weeks. And if relapse, second course of rituximab also can be given. At that time, you have to monitor lymphocyte subpopulations every few months, can help assess treatment response. Rituximab can cause hypogammaglobulinemia, and other adverse effects include infusion reactions, opportunistic infections, and/or viral reactivation that causes progressive multifocal leukoencephalopathy. Splenectomy, it's effective for children with chronic or recalcitrant primary AIHA. Approximately two-thirds show short-term improvement, usually two weeks following surgery. Because of post-splenectomy, sepsis caused by encapsulated bacterial organisms in young children, a splenectomy should be avoided in children less than 3 years old and preferably delayed to more than 6 years old. Immunization against encapsulated organisms is important, and sometimes people who underwent splenectomy should receive antibiotic prophylaxis, should be instructed to seek immediate medical attention. Next, we have third line, that is IVIG danazol. Danazol is not really studied in children for AIHA, but there are few anecdotes where they've used it. Azathioprine and 6-MP affect T lymphocyte helper function, diminishing autoantibody synthesis and exerting steroid-sparing effect 2 to 3 months of therapy. Cyclosporin 1 to 3 mg per kg per day, divided into 2 doses 12 hours apart. MMF, tacrolimus, sirolimus, cytotoxic agents, monoclonal antibodies include obinutuzumab and anti-52 monoclonal antibody Campath. Then you again have bortezomib refractory AIHA. Proteasome inhibitor depletes plasma cells and affects antigen presentation. Spleen tyrosine kinase inhibitors, fostamatinib, therapeutic plasma exchange, HSCT, complement inhibitors, all of these can help. Coming to secondary AIHA, the key is to treat the underlying cause. Sometimes that is a successful treatment may also improve the AIHA, but that is not always the case because the strength and association varies. So in Evans syndrome, you can give glucocorticoids and IVIG, rituximab, MMF, and sirolimus. Splenectomy, patients who fail medical therapy, then they can go for splenectomy. Immunodeficiencies like AIHA may occur in patients with CVID, WASC, TLA4, haplo with autoimmune infiltration, LRBA deficiency and STAT3 mutations and HIV. ALPS is steroids, SLE is methylprednisolone 30 mg per kg per day for 3 days, and drug-induced AIHA. In cold agglutinin disease, there is intravascular hemolysis that can be triggered by bacterial or other febrile illnesses. Patients with CAD should avoid exposure to cold weather where possible and rest to protect the distal extremities. While in hospital, the patient should be kept warm, especially in the perioperative period. Cardiopulmonary bypass presents a particular challenge related to the usual practice of systemic cooling and cold cardioplegia. However, systemic normothermia and warm cardioplegia is a recognized method, and adjunctive eculizumab has been successfully used to cover the bypass surgeries. And patients should not receive cold fluids IV and use an inline blood warmer when recommended. So patient receiving steroids, so because of an increased risk for upper gastrointestinal complications. So this I've just encompassed all the, I've not limited to one age group, but generally anybody on steroids, they have upper gastrointestinal complication. Antacid therapy such as proton pump inhibitor is recommended in patients taking these steroids. And they have high risk for developing peptic ulcer, especially in age groups of more than 60 years. And then you have concomitant non-steroidal NSAIDs, anticoagulant and aspirin use. So all of this becomes risk factors while using steroids. There's a risk of fractures when you use glucocorticoids for more than 3 months. It is recommended that these patients are advised about lifestyle modifications, smoking cessation, limiting alcohol intake to 2 units per day, and engaging in regular weight-bearing exercise, and maintain adequate daily vitamin D 600 to 800 international units and calcium 1000 to 1200 mg intake through diet, if possible, or supplements if needed. In addition, for adults more than 40 years of age, the initial absolute fracture risk should be estimated if available to determine whether an oral bisphosphonate should also be prescribed. However, some guidelines also recommend that older men of 50 years of age and postmenopausal women are at sufficient risk that that treatment may be considered without further assessment. So these are all the important aspects of AIHA, first line, second line, third line drugs, how you approach, and when you have to be aggressive, when you can wait and evaluate further. Thank you.